on page 115, we want to speak briefly about some pathologies and disorders affecting the cerebral cortex. What is viral encephalitis? So obviously that's a viral infection of the cerebrum, and depending upon which parts of the cerebrum is damaged, it might result in a certain deficit in brain functioning. If the viral infection has damaged the primary motor area, then there will be a motor deficit, a loss of motor control. If the virus has damaged the language comprehension area, that would affect the ability to understand language. Cerebral palsy. What's CP or cerebral palsy? This is actually damage to the brain, usually a motor area, resulting in a motor deficit, an inability to move the voluntarily control skeletal muscles compared to normal, and it's usually due to cerebroischemia, insufficient oxygenated blood going to a motor area of the brain or some other area of the brain. Whether this happens in utero, in the womb, so that the fetus doesn't at some point get adequate oxygenated blood to some part of its brain, so the baby is born with cerebral palsy, or perhaps later in life, somebody suffers damage to an area of the brain because of cerebroischemia, not enough oxygenated blood, so that area of the brain is damaged. We've all seen people with cerebral palsy. They are commonly in motorized wheelchairs. They have trouble coordinating their hands. They may or may not be able to walk. They may have difficulty in speaking, and so that's called cerebral palsy. What is dyslexia? Dyslexia, we wrote, is an inability to properly read and write words. It's where somebody is, quote, dyslexic. They have trouble reading and understanding. Some examples of dyslexia, and just before we describe them, as I give you these descriptions of dyslexia, everybody hearing this, watching this video is going to say, my God, I've got dyslexia. Well, we all do what I'm about to say, but it shouldn't be pronounced. It shouldn't be constant. Skipping over the word such as not when reading. So we've all read a sentence and we just kind of ignored the word not, so we actually misunderstood the sentence entirely. This is why on my exams, when we have a multiple choice question and we ask which of the following does not occur, so I always write the word not in bold letters, underlined, and all in capital letters so that you don't skip over that. But if somebody constantly, consistently skips over certain words, that would be dyslexic. Reading letters incorrectly, substituting, thinking that a letter B was a D or a letter D was a B. So instead of reading the word bad, you read the word dad, or vice versa. Or you were reading or writing the word, you wanted to write the word or read the word was, and instead you wrote it out saw. You reversed the position of the letters. These are all examples of dyslexia. Now, we wrote about 15% of children exhibit some degree of dyslexia. It is much more common in males than in females. Clearly, there's a problem in the brain, in the cerebral cortex. One theory was a lack of cerebral dominance. Remember, the language comprehension area, like the Wernicke's language comprehension area, like Broca's speech center, are normally in the dominant hemisphere. Or there may have been some sort of injury or damage, or congenital, the person was simply born with defects in the language comprehension area, Wernicke's area in the dominant hemisphere. The next term is cretinism. What is a cretin? There's a picture of a cretin right here. A cretin is an individual who is physically short, but in addition to being physically short, they are mentally retarded. And cretinism results from a deficiency of thyroxine from birth. Thyroxine hormone is necessary for not only normal growth and development physically of the body, but also the brain, which is part of the body. And so a deficiency of thyroxine will mean that the entire physical development is slower than normal, and the individual will not grow and develop normally, and they become physically short and mentally retarded. It's actually why, because this is so serious, if a baby is born with hypothyroidism, that in the state of California and most other states in this country, there is a number of mandatory blood tests that are required to be run by state law on every newborn infant. This is where they usually draw blood from the heel, and they run some blood tests, and one of the mandatory blood tests they run is for thyroxine hormone levels. If the newborn baby is found to be have hypothyroidism, they immediately put them on Synthroid, synthetic thyroxine, and by putting them on Synthroid, they will physically develop normally, and they will not become mentally retarded, resulting in cretinism. Now, the next term is very important: cerebrovascular accident, or stroke, CVA, or stroke. Cerebral vascular accident. It sounds like a problem with a blood vessel to the brain. So this is where there is damage to the brain because of a decrease in blood flow to the brain. Now, whenever there's a drop in blood flow to the brain, this causes cerebral ischemia. Ischemia means insufficient oxygen. And if there's not enough oxygen to the brain for any length of time, it will result in those brain cells dying. That's called an infarction. The word infarct means death, cerebral infarction. These terms, ischemia and infarction, can be applied to any tissue of the body. Any tissue that's not getting enough oxygen is ischemic. Any tissue that dies is called infarcted. So we use these terms, for example, not only in the brain, but with the heart. So there is myocardial, heart muscle ischemia, and myocardial infarction, where the heart muscle dies. And in fact, when heart muscle dies, when you have a myocardial infarction, that's commonly known as a heart attack. And where the brain dies, that's commonly called a stroke. Now, as far as the etiology or reason why was there a drop in cerebral blood flow, it could be because of a cerebral thrombosis. A thrombosis is a blood clot obstructing the flow of blood through a blood vessel to the brain. It could be a cerebral hemorrhage. Hemorrhage means bleeding, where a blood vessel bursts or pops, and then there's bleeding, and some part of the brain isn't getting adequate flow of oxygenated blood. This might be because of high blood pressure causing a bursting of blood vessels in the brain, or it might be associated with what's called an aneurysm. What's an aneurysm? An aneurysm is a bulging weak spot in the wall of a blood vessel. On the next page, page 116. On page 116, we want to just remind you that the brain is really unique in that it has four arteries, two pairs of arteries that supply oxygenated blood to the brain. There's no other organ that has four arteries supplying oxygenated blood to it. What are these four arteries? A right and left internal carotid artery that travels up the neck, passes through the carotid canal of the skull, bringing oxygenated blood into to the base of the brain, and also the right and left vertebral arteries. And the vertebral arteries branch off the subclavian arteries, and they travel up through these transverse foramina in the cervical vertebrae, and they pass through the foramen magnum, the big hole at the base of the skull, going in through that same opening that the spinal cord goes out through, also bringing oxygenated blood to the brain. Now, the reason for why there are four arteries bringing oxygenated blood to the brain is really a fail-safe system. so that if there were to be a reduction or blockage of blood flow to one of these arteries, you still have 3 arteries bringing oxygenated blood to the brain. And I might mention that all of these blood vessels are interconnected by anastomoses known as the cerebral arterial circle, or circle of Willis at the base of the brain. Nevertheless, there can still be, in spite of this fail-safe system, it still may not be sufficient, and with a blood clot or hemorrhaging, rupturing of a blood vessel, it can still result in a CVA or stroke. Now, the symptoms, as we wrote on page 116, the symptoms of the stroke or cerebrovascular accident really depends upon which area of the brain died. This could include aphasia. We've mentioned aphasia already is the term we use for damage to the Broca's speech center, resulting in an inability to speak, paralysis of the limbs, inability to move the arms or the legs because of death of some area of the primary motor area in the frontal lobe of the cerebral cortex, or depending upon exactly which area of the brain dies and how extensive, it might even result in death. Now, if somebody does survive a stroke, a CVA, so they may work with a speech therapist, they may work with occupational therapists, with physical therapists, to try to regain the ability to speak, to regain the ability to move their arms, ability to try to regain the ability to walk. So the question is, what's going on? Is the area that was dead coming back to life, that the person is then able to speak after a period of time or walk again? And the answer is no. But the brain very uniquely exhibits what we call neuroplasticity. And this is where if one area of the brain dies, surrounding areas of the brain that are still intact, still functional, can be sometimes retrained to carry on the functions that the dead area used to do. And so this allows the person to regain, at least to some extent, some of the capacity that they had before they suffered the CVA or stroke. Now, the next term that we've listed is epilepsy or epileptic seizures. What is a seizure? A seizure, epilepsy, is really due to increased electrical activity in the brain, such that there is an altered state of consciousness, either a loss of consciousness or some sort of altered state of consciousness. It gets the term seizure because literally normal consciousness has been seized or taken away. And that's what we wrote. On page 117, so there are many different types of epilepsy or seizures. This is a large subject, but we'll just give you a few examples. One type of epileptic seizure, probably the type we're most familiar with, is what's known as a grand mal seizure. Grand mal literally means big, bad seizure. And it is the kind where the person does lose, there is a loss of consciousness. They typically will fall to the ground, and then it will be manifested by convulsions. Now, what are muscular convulsions? Muscular convulsions are involuntary contractions of the skeletal muscle, and this is because of the increased electrical activity in the brain. Some of it is transmitted down the motor tracts, activating somatic motor neurons, which in turn activate skeletal muscles, so there is these gross, grotesque, involuntary contractions of the skeletal muscles known as convulsions. So do note there is a difference between the terms seizure and convulsion. A seizure is an altered state of consciousness or awareness in the brain. Convulsions are involuntary muscular contractions as a result of these seizures, as a result of this increased electrical activity in the brain. All types of epilepsy are associated with a seizure, but not all types of epilepsy is associated with convulsions. I did mention right at the beginning that commonly people who do suffer from grand mal seizures, or really many types of seizures, it may be preceded by what's known as an aura. An aura is a sensation that the epileptic seizure is about to begin. And it may be a sound that they hear in their mind, not a real sound, but a sound that's in their mind that gets more and more, louder and louder and louder, more and more intense. Or it might be an odor, a smell, not a real odor, but something that they are smelling in their mind. And the sensation that is created may be related to which area of the brain is exhibiting an increase in electrical activity in the brain that is starting to spread to other parts of the brain. In a grand mal seizure, the person will not only convulse, they may lose bladder control, resulting in incontinence. That's called incontinence. And following several minutes of this seizure and convulsions, the person may be either in a state of stupor or simply go to sleep and basically be quite disoriented. Now, in contrast to a grand mal seizure, a big bad seizure is a petit mal, a little bad seizure. And this is almost like a staring spell that lasts only a few seconds. There is no accompanying convulsions, no involuntary muscular contractions. And many of us, when we hear about this petit mal seizure, we might mistakenly think that it's when we simply let our mind lapse. We might be staring off into space, and you might think, so I've had a petit mal seizure. Well, that's not a petit mal seizure. When we are simply having daydreams or letting our mind wander, we know where we are, we just don't care to be paying attention to what's going on around us. But in literally a petit mal seizure, the person briefly loses consciousness. What is the cause of epilepsy? There are many causes, possible causes. It could be caused by an injury to the brain, resulting from a tumor, a stroke, a CVA, or an infection such as viral encephalitis. Less commonly, it might be due to a metabolic disorder, low blood sugar levels, very low calcium levels, or uremia. What is uremia? Uremia is an elevated urea level in the bloodstream, and the most common reason why somebody would have elevated levels of urea in the bloodstream is because of kidney failure, where the kidneys, whose job it is to excrete this waste product formed from the breakdown of old proteins to excrete it out of our bloodstream into our urine. If the kidneys are failing, the elevated levels of urea damage the brain and the brain cells and might cause seizures. The most common cause of epilepsy is said to be congenital or idiopathic. What does congenital mean? It means it's there from birth, congenital with birth, and they really don't know what the cause is. Now, as far as the treatment of epileptic seizure, really there's nothing you can do at this time once the seizure begins. If somebody is experiencing a grand mal seizure, simply open up their, if they have a tie, loosen their tie, make sure that they don't bite their tongue. You might put something into their mouth so they don't bite their tongue, and reassure the person after they awaken from the stupor. But the main approach towards epilepsy is preventing or reducing the incidence of epileptic seizures. Now, since an epileptic seizure is due to abnormal increased electrical activity in the brain, it stands to reason that the primary drugs used to reduce the frequency of epileptic seizures are central nervous system depressants. Depressants slow down. They inhibit electrical activity in the brain and therefore reduce the incidence of these epileptic seizures. Obviously, one of the side effects, therefore, of many of the anti-epileptic, anti-convulsant drugs anti-seizure medications is because they slow down electrical activity in the brain, they tend to cause drowsiness and lethargy and fatigue and so on. There are many types of anti-epileptic drugs depending upon exactly which type of epilepsy somebody has. The very first drugs that were used was sedatives, barbiturate sedatives like phenobarbital. But now we've got better drugs. The next area of the brain, now that we've completed the cerebral cortex, is the cerebellum. Now, the cerebellum, the word literally means little brain, and on my motto of the brain here, this is the cerebrum, and right here on the back side, posterior side, are the lobes of the cerebellum. So it means literally small brain. Now, this diagram summarizes the various inputs and outputs associated with the cerebellum. And we see that the cerebellum receives sensory information from the vestibular apparatus in the inner ear, which we know provides information about spatial sense, rotation, and spinning, and so on. It also receives a lot of sensory information from peripheral proprioceptors throughout the body, muscle stretch receptors, proprioceptors in the joints and in the tendons. And the cerebellum assesses all this information as well as receiving signals from the cerebral cortex. And it takes this information and it basically activates signals along the extrapyramidal tract, the involuntary pathway, to affect activity of our somatic motor neurons in controlling our skeletal muscles. So basically, the cerebellum plays a key role in coordinating skeletal muscular movements and ensuring that our movements, our voluntary skeletal muscular movements, are smooth and coordinated and take into account balance and equilibrium. Now, an analogy that I like to give for the cerebellum, and it's admittedly overly simplified, is the following. In the military, in the army, so a general gives an order that he wants the troops moved from point A to point B. Now, does the general actually have to go out onto the battlefield and lead the troops from point A to point B? And the answer is not likely. What the general relies upon is a high-ranking officer, we might say an officer with the rank of colonel or a captain, and this colonel or captain on the battlefield will actually lead the troops and take care of all the details that are required in the logistics of moving the troops from point A to point B. So in a somewhat similar fashion, the cerebral cortex, via the primary motor area, wants to move your arm from point A to point B. But what the cerebral cortex relies on is the cerebellum to take into account all this balance and equilibrium information from all these proprioceptors and to deal with all the details, the logistics of which muscles to activate and how to maintain balance and coordination to move the hand from point A to point B. So who's the general in charge? The cerebral cortex. Who is the high-ranking officer that actually deals with the details of the movement of the activation of the skeletal muscles to move the hand from point A to point B? The cerebellum. On the next page, on page 118, so we've listed that the cerebellum on page 118 unconsciously maintains body posture and balance, and it unconsciously coordinates voluntary motor activity. Commonly, one of the ways that we understand how different brain areas work, and obviously there's a tremendous amount that we don't yet understand about any of these brain areas, But one of the ways we try to understand brain, the different parts of the brain, is to see what happens, what are the clinical symptoms of when somebody suffers injury and a lesion, damage to some part of the brain. So we've listed down below, right here on page 118, what are some of these clinical symptoms associated with cerebellar lesions or injuries to the cerebellum? So one of the symptoms would be cerebellar ataxia. Ataxia is a loss of coordination. The person is still able to move their hand from point A to B, or move any other of their skeletal muscles and the other parts of their body, but they lose this coordination. So the movements tend to be very unsteady and exhibit difficulty. We might see intention tremors and unsteady movements during movement. That's what the picture at the bottom is trying to indicate. Perhaps you've had a physical examination at one time or another, and the doctor might have asked you to take your finger and touch a moving, the doctor's moving finger or the moving pen. And any normal person should be able to take their finger and move it from, say, their nose to a moving pen, and pretty smoothly and in a coordinated way move their finger from point A to point B, even if it's moving. But if somebody has suffered damage to their cerebellum, while they can still voluntarily move their finger, the movement will show a great deal of unsteadiness. What are called intention tremors. Another symptom of cerebellar damage is not only does it affect voluntary movement of our arms and legs, but it also affects speech. Because obviously in order to speak, it requires coordination of our vocal cords, our lips, our tongue. And so the person exhibits hesitating and slurred speech known as dysarthria. Dysarthria is kind of the opposite of somebody who is articulate, who speaks well. This would be disarticulate or dysarthria. In fact, the dysarthria kind of appears very similar to somebody who's drunk, who might be trying to speak. But it's not because the person's drunk, it's because the cerebellum has been damaged and there is difficulty in coordinating the movements. Another symptom is a flaccidity or weakness to the muscles. Another thing that you might have experienced in a physical exam is a doctor might have taken your arm and simply said relax, and they maybe alternately flex and extend your arm at the elbow. They might do something similar at your knee and move your leg. And normally, when you move an arm or a leg, when somebody's moving it, it should not be overly flaccid and it should not be overly resistant or tense. If there is somebody who's relaxed, it either feels almost like a very flaccid, almost wishy-washy, the movement, that's called hypotonia. On the other hand, if there was an exaggerated amount of tension within the arm muscles or leg muscles, more than what is regarded as normal, that would be called hypertonia or muscle rigidity. And in the case of damage to the cerebellum, there tends to be this flaccidity, this weakness to the muscles. We'll get into in a moment where damage to the basal nuclei or basal ganglia, as in Parkinson's disease, is associated with muscle rigidity or hypertonia. And lastly, another symptom of a lesion or injury to the cerebellum is a decomposition of voluntary movements. I wrote running upstairs. All of us should normally be able to just run up a flight of stairs without having to actually watch our feet land on each step. But somebody who has suffered from cerebellar injury would literally, while they could certainly go up the flight of stairs, they would probably have to watch the movement of their feet up each set of steps. If there's an old expression, what is it? You can't walk and chew gum at the same time. Well, all normal people should be able to walk and chew gum at the same time, but not necessarily if somebody has suffered lesion or injury to their cerebellum. They might be able to walk, but not chew, and if they're going to chew, they'd have to stop walking. Again, what they're lacking is the cerebellum that subconsciously, involuntarily, takes all this proprioceptive spatial information and it coordinates our movements so that our cerebral cortex, our conscious area of our brain, doesn't have to focus its attention on every single detail in the commanding of the somatic motor neurons and the activation or inhibition of the different skeletal muscles. On the next page, on page 119, another area of the brain also associated with affecting somatic motor neurons and skeletal muscular activity are the basal ganglia. Now, the word ganglia applied to an area of the brain is a misnomer. You might say, what word did you just say? It's a misnomer. It's misnamed. Because ganglia, by definition, means a collection of neurons located outside the central nervous system. Well, there in fact is a term, an anatomic term used to refer to a collection of neurons within the central nervous system, and that word is nucleus. A nucleus is a brain center. So really, rather than calling this collection of neurons in the brain a basal ganglia, it would be better to call it basal nuclei. In fact, the best term is to call it subcortical nuclei because its actual location of these neurons is just below the cerebral cortex. In this kind of three-dimensional transparent view of the cerebral hemispheres, it shows this complexly rotated mass of gray matter of neuron cell bodies that comprise the so-called basal ganglia or basal nuclei. And there are really a number of these that are linked together. They include the caudate nucleus, they include the lentiform nucleus, they include the amygdaloid nucleus, and collectively they're just called the basal nuclei or subcortical nuclei. Now, it appears that these areas of the brain, as we wrote below, primarily exert an inhibitory influence on the somatic motor neurons. And by exerting an inhibitory influence on the somatic motor neurons via the extrapyramidal tract, this involuntary pathway, it actually, this area of the brain inhibits activation of somatic motor neurons that control our skeletal muscles. So that means that if these areas of the brain normally inhibit somatic motor neurons that control our skeletal muscles, if there was a lesion, injury, or disease of this area of the brain, they wouldn't be able to exert their inhibitory action, and the result would be a loss of inhibition and therefore overexcitation of the somatic motor neurons, activating the skeletal muscles. An example of what we're saying is on page 120. On page 120, we wrote that when there is injury or lesion to the basal ganglia, there are resting tremors, muscle tremors, where the person exhibits the involuntary activation of somatic motor neurons to the skeletal muscles when they're at rest. Interestingly, when they're actually moving their hands, the tremors go away. So this is in contrast to injury to the cerebellum. In the case of the cerebellum, we said that these intrenchant tremors appear during the movement with the cerebellar lesion. In the case of basal ganglia lesions, the tremors are exhibited at rest, and they tend to go away when the person actually moves. Furthermore, in contrast to the lesion of the cerebellum, damage to the basal ganglia is associated with increased rigidity, increased tonus or tension within the resting skeletal muscles. So there is this rigidity or hypertonia. In contrast with the cerebellar lesions, there was a flaccidity, a limpness, a hypotonia to the muscles. And there's thirdly, a delay in initiating movement. An example of a basal ganglia disease is Parkinson's disease or Parkinsonism. And so people with Parkinson's disease, unfortunately we've seen images of Michael J. Fox, who developed Parkinson's disease at a relatively young age. Usually people who develop Parkinson's disease is much older. We see these involuntary tremors that exist when he's just sitting in one place, and the delay in initiating movement. There is almost a kind of mask-like quality over the face where the person doesn't exhibit normal facial expressions. It appears that underlying Parkinson's disease is a deficiency of the neurotransmitter dopamine. And dopamine is one of the neurotransmitters released by certain neurons in this area of the brain. Now, if you're wondering, isn't that an excitatory neurotransmitter? And didn't we just say that the basal ganglia or basal nuclei normally exert an inhibitory action on the somatic motor neurons to the skeletal muscles? The answer is that the dopamine, yes, is excitatory, and it actually activates other neurons in the basal ganglia that release inhibitory neurotransmitters. So literally, it's because of deficiency of an excitatory neurotransmitter, dopamine, that there's not enough activation of this inhibition by the basal ganglia. Anyhow, the treatment includes administering or for the person to take what's known as L-DOPA. And DOPA, we know, is a precursor to the formation of dopamine. You might ask, well, why don't they just have the person take dopamine directly? But dopamine does not readily cross the blood-brain barrier. But the precursor to dopamine, DOPA, does cross the blood-brain barrier, and the neurons then absorb it, convert it into dopamine, and that has some benefit in helping to manage Parkinson's disease. Returning back to page 108, on page 108 we had our simplified flow chart of which areas of the brain are associated with which activities. And I wanted to just summarize these areas of the brain that affect skeletal muscular activity. So first off, we know that what's controlling our skeletal muscles are somatic motor neurons. And we know that somatic motor neurons can be controlled by both a voluntary and an involuntary pathway. The voluntary pathway originates in the primary motor area of the frontal lobe of the cerebral cortex. And this allows voluntary control via the pyramidal or corticospinal tract on our somatic motor neurons. And this we can exert both excitatory or inhibitory influences on the somatic motor neurons. And therefore activate somatic motor neurons to activate skeletal muscles, or inhibit somatic motor neurons to prevent skeletal muscles from contracting. And this is needed when we exert fine motor control. There is also the involuntary pathway. The involuntary pathway, or extrapyramidal tract or extracorticospinal tract, originates in the midbrain. And it in turn is affected by signals from both the cerebellum and the basal ganglia. And the cerebellum can exert both excitatory and inhibitory influences on the extrapyramidal tract, which in turn exerts excitatory or inhibitory influences on the somatic motor neurons. The basal ganglia, or basal nuclei, we've now learned exerts primarily an inhibitory influence. An inhibitory influence on the extrapyramidal tract and therefore the somatic motor neurons. So what we're trying to say is this. As long as all these areas of the brain that affect motor activity, activity of our skeletal muscles are in balance, then we exert normal control over our skeletal muscles. If there is injury to the primary motor area of the cerebral cortex, if there is injury to the cerebellum, if there's injury to the basal ganglia, then this changes this overall balance of excitatory and inhibitory influences. We did learn that lesions or injury to the cerebellum commonly present different symptoms than injury or lesions to the basal ganglia. These included that we said injury to the cerebellum usually presents itself with intention tremors while moving and a kind of limpness or flaccidity to our muscles in the relaxed state and a loss of coordination. In contrast, we learned that injury or diseases of the basal ganglia is where there's a loss of inhibition, and so the person exhibits resting tremors that tend to go away when the person actually moves, and a kind of rigidity, hypertonia, and increased tension within the muscles in the relaxed state.